But for some reason, we can't get past that idea of that simulation, even in practice and nursing education across the gamut, is going to improve patient care. And I think that's the misconception that always kind of gets me, is that simulation will help improve patient safety.
Simulation in nursing doesn't have to be intimidating. Today, we'll learn how to make it work and why it matters more than ever. Welcome to the Lippincott Spark, Illuminating Nursing Education podcast. I'm Dr. Kelly Drees. Join us as we ignite your passion for nursing education and leadership. We'll explore the latest trends, hear from expert nurses, and provide tools to keep you inspired. Let's dive into today's episode and continue your professional development journey together. Today's episode explores one of the most exciting and sometimes intimidating tools in modern nursing education, simulation. From virtual reality to high-fidelity scenarios, simulation is reshaping how we prepare the next generation of nurses. But how do we integrate it into our curriculum effectively? What are the best practices, and how can we overcome the anxiety many faculty feel about using it? To help us unpack all of this, we're super excited to welcome someone who's truly shaping the future of nursing education, Dr. Elizabeth Wells-Beede. Elizabeth is the Senior Associate Dean and a Professor of Nursing at the University of North Texas Health Science Center. She's a nationally recognized expert in using simulation and virtual reality to train the next generation of nurses. And she's secured over $20 million in funding to support this groundbreaking work. Welcome, Elizabeth.
Thank you, Kelly.
I thought we could just start with the basics, how simulation became such a powerful tool in nursing education and what it really means in practice. So I'm curious about what first drew you to simulation as a teaching strategy.
I think I kind of go back to actually when I was a student. I won't say the year, so I don't date myself too much, but we were using simulation in labs at that time. I mean, we didn't really think about it in the same way that we do after the landmark study, but we had a lab. We would hang up IVs, put them on the pumps. We would use oranges to be able to try to do IM injections. With our peers, we did our partner assessments on one another. But I had a particular faculty that was an amazing faculty and a mentor for the majority of my career. Even after I was out of nursing school, I always idolized her as an amazing faculty. And she really used simulation in a lot of different ways to help us learn within the classroom, within our clinical setting. And I think for me as a learner that really truly likes something that's hands-on, I am definitely one of those learners that's experiential. I always was drawn to it. So when I went into practice and I started working in labor and delivery, I was one of the first ones to right away start helping to teach and become part of the education team at our hospital. And so using low fidelity mannequins for CPR, ACLS, newborn resuscitation. We used a lot of them for some of the A1 training because there were some things that we had to do with A1 training that we had to be able to do that. Just the task trainers for insertion of Foley's. And then I had the opportunity when my husband was stationed in Germany, as spouses that go with our military husbands, sometimes there's the disadvantage that we are unemployed. And so I had the amazing opportunity that was brought forward to me by another nurse that was actually doing school nursing. And she told me, hey, we have this opportunity at our medical group to potentially be able to bring simulation into training for the military members at that particular base. And so the Air Force Surgeon General back in 2010 or 2011, had put forward an initiative to bring simulation across all of the military platforms in the healthcare setting to be able to help prepare those medics that were going downrange during times of combat. And because it was easier to try to find ways to train them if they were stationed overseas, as opposed to paying for them to continue coming back to the States for the training that they were needing in order to stay competent downrange. And so I applied for the position, and I was the first one to lead their team and really develop their simulation program in Germany. I think almost everybody that starts simulation as one of the first talks about the gigantic box that had this 350-pound mannequin, which was at the time was the CAE mannequin, and he had all of these bells and whistles, computer, compression, like all of this stuff. And I had to basically teach myself with our sales rep overseas. And after that, I think I just really pulled myself into it even more and really started engrossing myself into it, because that's when I realized that this is the most amazing opportunity to be able to teach anybody in any health profession, but especially in nursing and undergraduate and graduate nursing, because it's the opportunity to practice something without harm. And that's one of those amazing things. And so I think I just continued pulling myself forward and just loved it ever since.
That's fantastic. I love that. And I can definitely relate to that 350-pound mannequin in a box. I walked into one of the institutions I worked for and found a large box in the back of the storage closet in the lab. And I thought, ooh, what is this? This is very exciting. And, it was like Christmas. And I opened it up, literally $100,000 mannequin sitting in a box. I thought, what is this in the box? Why aren't we using this? And I asked the program chair, and she said, well, the simulation faculty left, the one that knew about simulation, and no one knew how to use it or set it up. So it's just been sitting in the box for a couple years. And I thought, oh my gosh.
Wow.
So, it kind of brings me to, many faculty feel very overwhelmed by simulation. So what do you think are the common misconceptions that you encounter?
For me, I always think of, as I had mentioned a little bit earlier, I'm an experiential learner. So having the opportunity to pick something up, do something, perform, and go back, oh, I made a mistake, really be able to bring that whole thing circle and be able to practice again has always been my personal favorite way of learning. Not everybody learns that way, and we know that as educators. So I think sometimes when you're putting something on somebody that one isn't comfortable with either that mode of learning or teaching because it's not their comfort zone, then I think that ends up being the difficult way of getting those people to end up adopting simulation. I think that's why it's been such a struggle. I think some of the common misconceptions that I can encounter, and that I really always kind of go back to a couple of different things when I encounter this misconception, and it's that it's better to have actual face-to-face clinical. They get more out of face-to-face clinical and being with the patient than they do in simulation. I agree and I disagree. I absolutely believe that students need to have, that's how you assess competency, right? Students have to be able to do with the patient in the hospital setting. And that's what we're gearing towards. However, if you're following the NCSBN guidelines from the 2014 landmark study, and you have faculty trained in simulation and doing simulation that's accordingly aligned to the objectives, outcomes of the courses and the program, and faculty are trained on how to pre-brief, facilitate, and debrief, simulation has just as much power to teach, and sometimes, if not more, appropriate behaviors and safe practices for students so that they're practicing safely with patients in the healthcare setting. Part of the reason that I always kind of go back on this misconception that it's not the same value, or that, oh, well, yeah, they could just do it in the hospital. And when somebody tells me that, I usually say, and I had a faculty laugh at this one time because they were like, oh my God, I never even thought about this. And Dr. Carter-Negrin says this a lot, in that when I get on a plane, I am pretty much almost 100% sure. I get on that plane because I have all the confidence in the world that pilot and that co-pilot that are flying me from one place to the other, I just went overseas recently, that they are trained and they know what they're doing. And interestingly enough, their training is heavily reliant on simulation. They are required to do simulation checkoffs. I think it's every 6 months. They cannot fly if they don't do these simulations. And so it's always interesting to me is, if you want to get on that plane, do you want to know that pilot's doing those simulations? Because I do. I'm not going to get on the plane if he's not doing those.
Mm-hmm.
They're not doing those simulations,
not.
right?
Yeah.
But for some reason, we can't get past that idea of that simulation, even in practice, in nursing, education, across the gamut, is going to improve patient care. And I think that's the misconception that always kind of gets me, is that simulation will help improve patient safety.
There's some confusion that faculty have on using the word fidelity, right? So Can you explain a little about what fidelity really means in simulation and why it's not just about the equipment? Because when you think about fidelity, it's like, well, we got to have that mannequin with all the bells and whistles, and it might not just be the equipment, right?
So it's interesting that you asked this, because this is something that's kind of been circulating in the sim world and conversations that have been coming up, and that with anything, as a pedagogy grows, as literature becomes more engrossed with simulation and what we're doing, some of the common things that occurred back when, right? We used to think that it was okay to tell somebody they're going to kill the patient while they're doing a simulation. And we know that that completely negates any of the learning whatsoever, or manipulating it so that they see something is occurring. We know that that's not best practices anymore. Fidelity was one of those things that we did really kind of associate with the fidelity of the equipment or the modality being used. So, and we still say it, right? You have one that's used for a task trainer that's considered low fidelity because it doesn't have any of the bells and whistles. It doesn't have any of the response mechanisms that can occur while you're using it. It's just a task trainer for them to be able to do deliberate practice or to be able to practice something. We consider high fidelity a mannequin that has, like you were saying, all the bells and whistles, or a standardized patient, because a standardized patient is the highest fidelity that you can go to. So recent conversations and discussions in that, is it truly the fidelity of the modality or the equipment that you're using? Or should we really start looking at this more as of the fidelity of the actual simulation? So you can have a high fidelity simulation that is perfectly aligned to the outcomes and objectives of a program or a course, or what a hospital has actually told us, hey, we need some help on this. Can you please look at this with your students? Faculty are all trained appropriately. Students are all engaging and reacting appropriately. And it just be a role play. But because everybody is so engrossed and it's so well planned, the students may learn so much more from that experience than a task trainer. And so the fidelity of the actual experience is what we're saying is starting to be elevated, in that maybe is it deliberate practice that they're just going in and getting really quick feedback. That's a lower fidelity. And so when you look at it too, it kind of goes into that sim zones. I'm not sure if you're familiar, if you've seen anything in regards to sim zones. So that also kind of brings that fidelity higher, right? Where you may have at that end of sim zones, all the distractions. You have a simulation, it's an in situ. So there may not be all the bells and whistles, but you're actually in a hospital setting and bells are going off and people are interrupting you. And it creates this fidelity of what the experience is. And it really just kind of elevates it, as opposed to it being associated with the mannequin or the equipment being used.
Absolutely. I think of one of the experiences that the nursing students that I had worked with in the past had this kind of professional collaboration and did a simulation across the lifespan. So you had nursing, you had your respiratory therapist, you had PT, OT, speech, surge tech. The patient needed to have surgery, so you had the surge tech folks come in. And then, of course, barber cosmetology, funeral services. You can really make it really robust and high fidelity, to your point.
That sounds like an amazing simulation. I'd like to see that.
It was definitely transformational for sure. So let's talk about how you can weave simulation into the curriculum, what it takes to do it really, really well. So how can simulation be effectively integrated? And what are some best practices for launching sim into a program, and especially for programs that are just starting off, from scratch and don't really know where to begin?
I think this is one of the things that's always interesting and a little bit hard to really pinpoint really well, because everybody has different pots of funds. I mean, that really kind of sometimes is what ends up surmising really how you're going to be able to integrate. But it goes back to, again, the fidelity and what are you doing and how are you planning it? Because you can have a great simulation and not have the $100,000 mannequin, because it's really what are the students' experiences and kind of pulling out of it. I think for me, one of the bigger things is, because we have such a large amount now of research, literature, healthcare simulation standards of best practice, Society for Simulation Healthcare having the code of ethics. And we've come so far from that study in 2014 that was done in regards to 50/50 simulation, and that it showed that if you have adequate support So I think one of the big things is having administrative support, having support for the professional development. The main key component for putting any good simulation into a nursing program or curricula is understanding not only the curriculum and the curricula, but also understanding the pedagogy of simulation. You can't just plop it into a course and think that everything's going to run fine and that you're going to meet the outcomes and the objectives. If it isn't closely aligned to really what the objectives are and really what you're trying to assess for those learners, you're not going to know what competency is for that particular learner. So I think it's just, there's a little bit of a misunderstanding. I think that you can just take it and, oh, okay, I don't have clinical hours for this day. I'm going to go ahead and have them do X, Y, Z. Well, if it's not accordingly aligned with the curriculum, then the students aren't going to get anything out of it. And that's the important part, is making sure that is the biggest part of simulation, is we as faculty have the ability to be intentional of what we're doing, because we know that students need to understand a particular competency or care of a patient, but they may not see it in the hospital setting. So I always go back to like a postpartum hemorrhage. That is so important for the fidelity and how to look at that hemodynamic instability. One of the most common things, but every student isn't going to see a postpartum hemorrhage when they go to clinical setting.
Exactly. Yep.
But I could do it for them, and well. So I think that's the biggest part, is just making sure that it's understood, administrative support for looking at your state's guidelines as to what you can offer. We're very fortunate in the state of Texas that we're able to go up to the 50% following the guidelines of the NCSBN study. So we can be very intentional and be able to also kind of ease a little bit of the pressure from our clinical partners as well.
And it sounds like really ensuring that technology enhances the learning rather than being a distractor, right? A distraction.
Absolutely.
That it's very intentional and knowing the rules and regs. Absolutely. So if you find that you have a new faculty, where do you begin to train them? How do you train them? Is there a best practice in kind of that mentorship, and what happens when they're pretty resistant to it?
I mean, that's always the kicker, right? Is what if there's the resistance? I'm very fortunate at the moment. We're at about 43% for our pre-licensure program. And a lot of times, to me, sometimes the resistance is always asking why. Because I think sometimes, is it the uncomfortability because you're not familiar with it, so you're resistant? A lot of times, sometimes they're afraid that they're going to make a mistake as they're doing this with the students. And one of the things that I've always gone into preparation with the students and start off simulation with the basic assumption. And I tell them at the end of that basic assumption, I say, so I ask you to do the same for me. I want you to know that I'm coming in with the best intentions. I've done my best to be able to prepare to ensure that you're learning and you're learning appropriately. But we have a psychologically safe environment right now, and I may make mistakes, but I'm going to tell you, hey, that was a mistake. But if you see something, please let me know. And I don't know, I'm really comfortable with being uncomfortable. And I allow myself to be vulnerable at times. And I don't know if it's some of that vulnerability that some people don't feel comfortable with, because there is a little bit of that hierarchical component that you want the students to respect you, and you want them to be able to say, oh, okay, you're the faculty and I'm supposed to be listening. But I think there's that vulnerability component. So I would always kind of explore the why is there the resistance. And then also kind of circle back around, because if there's resistance, then how are things going in simulation if we're saying, no, you're going to do this? Because I also don't want a faculty member in there that is the one that's penalizing or not doing simulation with best practices, because then all that is going to do is subsequently cause harm to the students. So then do I need to reevaluate? May not be a strength, and that's why they're resistant. So I think it's really just kind of exploring and kind of getting into the weeds to ask why they're uncomfortable, because it's not going anywhere.
Of course, no conversation about simulation would be complete without diving into the role of technology, especially virtual reality. So let's talk a little bit about VR. You've led groundbreaking work in VR. How is virtual reality changing the game in healthcare education? And what are some challenges or opportunities that you see with using VR for clinical learning?
I think that there are exponential opportunities in using VR within all programs at any level, regardless of where you're going. So from start in pre-licensure, ADN, all the way into practice, and continued into practice. And so I think we're at a really somewhat amazing and scary impasse when it comes to, and I would actually really kind of shift the term into mixed reality, only because there's so many different layers now that are starting to come into what we have called virtual reality. And there's so many different terms that really kind of all fall under that mixed reality. And so it could be anywhere from VR, AR, it's everything screen based that kind of falls underneath that. And I think each one, regardless if it's screen based, Oculus headset, Apple headset, any of the headsets that actually take away a sense and you're immersed in that environment, or augmented reality, because there's a lot of programs that are now, coming out with augmented reality, and that AI is going to blow it all up. It is going to change how we're doing it, what it looks like, how we're assessing students and providers, and where we can go with what we're doing. And so I'm excited to see where some of it is going because of the opportunities that I have to continue to be able to develop. So I've, in my experience, have had the amazing opportunity since 2020 to be actually developing and creating VR simulations to be able to use with our pre-licensure and graduate students, as well as healthcare professionals. And even in just those 5 years, I can see significant differences in the first one we created to the one that we've just recently created. And it's amazing because in part of it is I collaborate with faculty member that uses students to create all of it. And so just to see the things that they're creating and the advancements that they're making and just their excitement to do this for a profession they know nothing about. So that's something that's really exciting. But I think it's also an opportunity, as we had mentioned earlier, when you're starting up a brand new simulation program, what are those things to look at that you can use in order to be able to really kind of stretch your dollar? And I believe virtual reality is one of those things. I think mixed reality, virtual reality, as it continues to grow and more companies are able to really kind of start perfecting it and making it more realistic, I think it really expands the opportunities to where now the dissemination of it and the corners of the nation, the corners of a state that typically wouldn't have it, the corners of the world that possibly would never have had the opportunities to do this, would have the potential opportunity. And I think that is one of the most amazing things about it, is that if it's encapsulated in a way and created that it can be really self-sustained at a moment and not necessarily need Wi-Fi. So that is, that's one of the downfalls, is technology always needs to pull in other technology. It's limitless. Like you can take it anywhere. And I think about just recently, Laerdal, there was, her name always escapes me, but she was one of the presenters, Hayden Vanguard presenters that Anaxel 2 years ago, and she did a study with Laerdal and actually took the low fidelity mannequins with her to help improve maternal morbidity rates in Africa. And they were practicing weekly, did an amazing job. I mean, they decreased and brought up the survival rates for maternal morbidity rates just by practicing and doing that. But I think of places like that to where you could send them a headset and they could practice every day if they wanted to. The opportunities are just endless of where it's going and how it's going to be. And the part that's a little frightening is, as AI does start to develop and become a little bit more robust, is some of the augmented reality stuff. There's instances now with holograms. I watched an episode probably 2 years ago in regard to a Holocaust museum, that they actually took interviews of somebody that was a survivor and created an augmented reality hologram, and you can actually go to this museum and have a full conversation with this hologram AI. And actually, and it's like, well, wow, that's a little bit scary. So like those parts of it, I'm like, I don't know about that, but if used appropriately, I think that it's going to be amazing opportunities, because again, for those fidelity simulations, that you have a patient that maybe is experiencing a very rare disease that you may only see once in a lifetime, but you need to know about what could be the condition if they're walking into your ER, because there tends to be, a concentrated population somewhere. What a neat way to be able to have this interview with a person that's holographic images. It's
It kind of
exciting.
blows your mind, doesn't it?
It
It's
does.
like, wow. Well, and I know Lippincott, Laerdal have partnered, had launched VR clinicals, and with the conversational AI, just took it to the next level. It's simply amazing. So I think about what's next for simulation in nursing and how academic leaders, really need to stay ahead of the curve. Just like you said, there's so many things being built and changing every day. So what do you think the future looks like for, simulation in nursing education, and what should academic leaders be paying attention to?
I think that's a hard one because I think, again, it's just with the way technology is moving so quickly, I'm not even sure how easy it's going to be for us to stay ahead of it. Like there were moments in time that you could kind of see something that was coming out and you're like, oh, okay, I'm going to look at this and I'll be ahead of what it is. I feel because of the way everything is social media, AI, everything that's so entwined together, it makes it really hard to be ahead. But I do also think that there's the opportunity for us to not continuously be behind, which I feel like we have been in academia. The reliance on just a hardback textbook. And I know, like with LWW, you have the opportunity to continuously update things if a student is using an ebook. So using that electronically, things can be just like an operating system is updated. You can update it quickly to be able to bring in the newest evidence, because I think it was 5 years back, a study that said that medicine was changing at a pace of every 72 days, that something was changing in healthcare. I can't imagine how quickly it's changing now. Like that study almost has to be replicated to see how quickly everything is changing. But I think one of the things for academic leaders is, is always surround yourselves with those key people that are going to continue to improve themselves and want to grow and learn and are okay making mistakes, because I think that's the biggest thing, especially with innovation. It's riddled with mistakes. And if you're not okay with making mistakes and trying to learn from them, then you're going to be put in that fixed mindset. And so I think as an academic leader, looking at areas that may not necessarily be where we would typically go to. And I say that because for me, as we know, I call myself a simulationist. I've engrossed myself in researching simulation, being part of it, learning it, growing it. And so for me, going to simulation conferences, that's my comfort zone. That's where my people are. I love to see everybody there. I get to chat, I get to network, but there's times that I think as leaders, we kind of have to step out of that comfort zone and potentially go to those conferences or going to those areas that we may not have typically gone to before and outside of our industry. So not necessarily a nursing conference, but maybe I'm going to a digital health conference so that I can see kind of all these things that are starting to be done outside. Or maybe I'm going to a tech conference. AWE has a big conference every year. Maybe I'm going there because I think they're going to be on the forefront, and then bringing it back to academia, back to nursing and healthcare to help us stay at status quo with those people that are going to be on that forefront.
Before we wrap up, I'd love to hear your final thoughts. What is one spark of inspiration you hope nurse educators take with them after this conversation?
I think my one spark that I hope educators take with them after this conversation and hearing this podcast is it's okay to be vulnerable. And it's okay to be a little comfortable with being uncomfortable. Innovation is hard, and the failure isn't always easy, but we learn more from failures than we do from our successes. And I think understanding that it's okay sometimes to fail in order to become better.
Thank you so much, Elizabeth, for sharing your incredible insights and passion for innovation, and from really redefining fidelity to pioneering VR. I look at your work, and I follow you on LinkedIn, of course. You're not only transforming classrooms, but also shaping the future of healthcare. So, and to our listeners, whether you're a seasoned educator or just beginning to kind of explore simulation, just as Elizabeth said, remember, innovation doesn't have to be intimidating. Starting small, staying very curious, and surrounding yourself with champions like Elizabeth is always great. So until we meet again, keep sparking change and reimagining what is possible in nursing education. Thanks.
Thank you, Kelly, for the opportunity.
Thank you for joining the Lippincott Spark Illuminating Nursing Education podcast. Enjoy this episode, subscribe, share, and leave us a 5-star review. For more information, click on the link below to learn more about Lippincott Nursing products and services. Until next time, keep leading, learning, and making a difference in nursing education.